Okay, I think we are live. So let me share the screen. Good evening and welcome to our 25th Alameda County COVID-19 Community Advisory Group meeting. My internet is unstable, so I will try to go quickly. Wanted to welcome you here and announce that we have our meeting is interpreted live in Spanish and in American Sign Language. If you'd like to participate in Spanish, please select the globe below. If you are participating in English, also please select the globe below and select the language in which to participate. I'd love to ask Guillermo or Laura to announce that, and then I'll turn on the interpretation.
Hola, ¿qué tal? Buenas tardes a todos ustedes. Bienvenidos a nueva junta de la Agencia de Servicios de Cuidado de la Salud del Condado de Alameda. Para todas las personas que deseen escuchar esta junta en español, por favor, cerciórense de hacerle un clic en el globito que aparece en la parte baja de su pantalla y seleccionen la opción de español. Muy amables, gracias.
Thank you. I'm going to start it now. Also want to announce that we have live closed captioning, and to remind you, you can select closed captioning if you want to read and participate that way. So reminder to participants and presenters to mute yourselves when not speaking and speak slowly for our interpreters. And with that, I'm going to kick it over to our Public Health Director. Kenny Watkins, start.
Good evening, everyone, and thank you so much for being here. I want to welcome you on behalf of the co-chairs, myself, Greg Hodge, and Nestor Castillo, and hoping that this evening we will have a rich discussion, both, of course, about where we are with COVID and managing the pandemic and keeping people safe, as well as how we continue to adjust our tactics to move with the movements of this pandemic. We are learning new things all the time about COVID and about what it takes to keep our communities safe. And so we're hoping to have a really good discussion tonight. The staff have really good plans for us for that discussion. And so I want to start, though, us off with the partner updates and what we call lessons from the field. And this is an opportunity. Oh, yeah. So this is the opportunity for community partners to share a bit about what they're doing in their area, what they're seeing, what they're hearing. It's also an opportunity to pose questions that we want to also to have addressed as part of our conversation this evening. And so, Lauren, are there any partners who are already queued up to share, or are we going to? Yes?
No, there are not folks who are queued up to share, but it would be an invitation if there are announcements that people would like to make.
Perfect. So the floor is open to any community partner who would like to share a bit about what they're doing in their work related to COVID. No one wants to share?
I see Gabriela, hands up.
Yeah, I can share a little bit of what we're seeing. So just first and foremost, thank you all for being here in the space, and I'm glad to be here with you all. I just wanted to share a little bit, as you may have seen already, COVID really is around. It's really hitting our coalition partners. So in particular, street level, East Oakland Collective and La Familia have had staff out. And so we really see this impacting not just the community, but our staff as well. And so hopefully that they're able to have a conversation around how to keep our staff safe as well during this time. And we did change locations from where we were hosting our mobile vaccine clinic. And we actually were able to reach 59 people this month. And what we noticed was really is just, catching people as, they're on the street. Most of the conversations we were having with people this weekend was really people either had started their series of vaccination and maybe got the first dose or the second, but had not gotten their booster, or got the first dose and were very concerned about getting more vaccines. And so just having that connection right at the street corner, being able to just bring them into the vaccine clinic was very successful. And so I want to say just changing locations, being flexible to the strategy as was mentioned, and just, pivoting as needed has really shown success this month for us.
Excellent. Excellent. Thank you for sharing. Sheridan.
Yeah, that was a great update, Gabriela. And just to piggyback on what she just shared, we too have been just kind of evolving and being flexible with our approach. This last month, we worked on, over five like community health fairs, and then several, I think maybe 3 Juneteenth events across the state. And we're able to not only give out PPE and antigen testing, but then also direct folks to the vaccination booth that was nearby in partnership with those booths. And it was terrific. And we feel like, based on the feedback of attendees, we were able to reach a lot of folks that we hadn't been able to reach before. So we're continuing to look for summer and fall events, particularly those that are not health or public health related, but where we can just set up shop and be able to give out information and resources for people, try to capture folks that we haven't been able to capture before, to let them know.
Thank you for that. Thank you for sharing. Who else would like to share a bit about what you're doing in your work, in your community? Or even posing something that you would like to share with the group around what you're hearing and concerns that are being raised by the people that you're serving. Okay.
Yeah, I'm sorry, I couldn't let the opportunity go by. So Gary Blodgett Village Connect, I literally just, got into came back in from doing doors. The messaging out there is such that it's very difficult to break through, if I can utilize that mindset. Because we hand them information, we hand them masks, we hand them tests, and most of the individuals have such a nonchalant attitude about COVID now because of hearing it from so many different perspectives, that I would really love to see a grassroots unified effort that could message and contradict and not literally contradict, but the public health department. Unmasked, we should be out there saying, no, keep your mask on, which we are, right? We're handing out masks. We're literally, begging people to, maintain the course of self-care. But the numbers should be indicative of the fact that public health messaging is contrary to what the virus is doing, right? The virus is spreading, and it's going to be consequential with regards to lives being lost and other detriments to, our community. But I am really trying to see how we can bring all of the organizations together to have a singular message, even especially if we can do it across all 58 counties, but particularly Alameda County. We need to be saying the same thing out on those streets all the time. That is coming from not only, Deep East or unincorporated or what have you. It should be across the board that these messages should be clear, distinct, and the same. That it is causing less confusion. And then I'm believing that we will start seeing a difference in the numbers with regards to getting the population to believe. And I mean, because we're in the streets with them. And anyway, I'm complete.
Yeah, absolutely. Thank you for sharing, Gary, in terms of just, how people are hearing the change in the health orders. And we were, of course, afraid that this would happen, that as we, shift our strategy or shift, and shift health orders, like the masking order, that would be interpreted as you don't need to wear a mask and you shouldn't wear a mask. And that is not what we're saying. We're saying that it is no longer legally required in most public settings. We are not saying that you shouldn't wear a mask. We are absolutely saying you need to keep wearing a mask. The numbers are still high. We can all look at the data. We can see it. And what I was saying, here is that you can't turn around. No one of us probably can turn around without touching somebody right around us that has COVID right now in this moment. And so we have to take that seriously. And we need to do what we know we need to do, and which is keep our masks on and keep ourselves protected, get boosted if we have not been boosted yet, get vaccinated, continue the series. As you mentioned, Gabriela, there are quite a few people who started and they weren't quite sure about continuing on. Some people have gotten their primary series, but they're like, I don't know if I want to get boosted or not. I think I'm good, that kind of thing. And there are messages outside of Alameda County, of course, that, COVID's over and, that's behind us. And we all know, we can look around us and see that it is not yet behind us. Shirley.
Hi, good afternoon, Shirley from Street Level Health Project. What I've seen in the community and based on also the information I have gathered from the community members, I think they have expressed that there has been a lack of information from testing sites because a lot of people have come in and they want, like at Street Level Health Project, we have a hotline where people could call if they need any support with creating testing, get any appointments for testing, and we have signed up many people for testings, and sometimes they are successful, but sometimes they're not, because when we try to sign up people for appointments, this slots, they're already like full, and then but also on their website it says they could go for walk-in, but when they go for walk-up at the testing sites, those days the testing sites don't have any, they're not operating or they're not open. So the update, many of the testing sites haven't updated their website, has created this confusion, not just for us like as workers, but also for community members, because now they begin to look in other sites, but sometimes other testing sites are far away from where they live, because they do have a transportation issue, or there's a barrier with language as well. So that has been one of the concerns that a lot of community members have expressed. So sometimes they do rely on the rapid home test. However, not everybody can afford a rapid home test, or there's a lot of pharmacies around their neighborhood that don't carry them, or they're like already gone, or in the sense that there's no more rapid home tests. So that's what I've heard from the community, that there has been a lack of testing sites, but there are sometimes testing sites, but they do have a requirement of an ID. Not everybody has an ID. So therefore, that becomes even a bigger barrier from them to get tested. And which that has shown that there is a really quite high testing COVID tests or people who do feel like they have COVID. So that's how we noticed and seen that there is an increasement amongst that. And also not just the testing sites, but also the fact that also the Alameda County did kind of shut some of their vaccine sites. There are people who come in, and sometimes in the clinic, the mobile clinics that we do, we don't have access to certain sites or to certain information. And that kind of becomes hard for us to kind of look up for someone just having that access for their vaccine information, and then we have to turn them around. So that has also become a barrier, and we see that because we do have a monthly mobile vaccine, and sometimes we cannot fully help someone. So yeah, so those are the things that I have seen around the neighborhood and I've heard from people, and that's my experience with COVID for now.
Thank you for sharing that, Shirley. And that's important feedback for us to have in the impacts of sunsetting some of the vaccine sites that, you know, there was a pretty significant lull, and that, you know, people were not getting vaccinated. But I think that there are opportunities for us to better coordinate all of our mobile efforts so that there's more awareness of who is where, so that we can provide people with information of where they can get vaccinated. Because there are still a lot of boots on the ground out there. There are still a lot of vaccinators out there with vaccine, ready to vaccinate folks. But we all collectively do need to improve the way we share information about where we're going to be, where everyone's going to be, so that people know where to go. So thank you for that. Oh, thank you. Hi, Pastor Arlene. Go right ahead.
Hi, yeah, thank you. Sorry, I was a few minutes late to the party, trying to figure out how to fund and keep our food pantry open. So I 100% agree with Gabriela. You know, we're fortunate that La Familia is able to, you know, provide testing services pretty close to the church, and that's beautiful. But not everyone is so fortunate as we are. And, you know, of course, you know, the language equity, regardless of what your, and language justice, regardless of what your language is really important to all of our community members and so forth. And it's beautiful to see these multilingual flyers going out. Awesome, A+, that's a big improvement for our county. I know, because like for 10 years, that's all I ever like, where's the flyer in Spanish? You know, I could just wore myself out with that question. But you know, we've just done a couple of random, you know, call arounds and so forth. And we're finding that, you know, just when we need to refer our people, we're finding that at least some of the providers, the voicemail, you get voicemail, and the voicemail is only in English. There's no languages for other options and stuff like that. So, you know, to sort of, you know, just put the polish on, well, you know, and it's not really a polish thing, right? It's an access thing, is like, okay, that's beautiful. I know where I can go, but when I get there or when I call there, do they speak my language? You know, if I have a question, a health question, is there a person there to serve me in my language? So I'm probably preaching to the choir here. Thank you for listening.
Before you move on, and thank you, everyone. I'm sorry for the interruption. I truly wish that we could address the issue that Tina put in the chat, because who helps the helper when the helper is now impacted, right? A lot of our frontline workers have been out there literally engaging, and to their own detriment at times. So where is, you know, the support for our frontline worker and when they become impacted, because it is truly a life-altering experience. And I do believe that, you know, we need to address and or readdress that concern, because it is of such significance. And again, it impacts, you know, not just that frontline worker, but those families associated with it. I'll complete.
Yeah. Thank you for sharing, everyone. Thank you for sharing. Oh, Dr. Bruce. Someone said you raised your actual hand. Sorry.
I raised my artificial hand, not my actual one. So I have a couple of questions, and one, Gary, I agree definitely with, you have to say the same things across all boundaries, has to be distinct, definitely has to be the same, and that's one of the problems I'm hearing. I don't hear as much, obviously, because I'm not in the thick of where it is, and it needs to be a singular message of some kind that's pretty much across the board. One of the things I heard Shirley say was the people who go and get the vaccine need to show an ID. Did I hear that wrong, or did I hear that right? Because that can be a reason that people might not want to go to some of the vaccine sites because they don't want to give out too much information because they're worried that that might be used against them in some way. And is there a way that that can be handled? I do have something that's totally separate about where you are now. And I just actually talked to a couple of pharmacies to see what was happening with the Paxlovid. And that's having people come into the pharmacies really kind of not knowing what to do, but it isn't actually all the time the people who are ill. It's a teenage daughter, etc. And the relatives are now getting that. Now, where I live, we're considered, sort of upscale, etc. And it's still happening at the CVSs and at other types of pharmacies where that's being allowed. The actual person who is ill, quote unquote, is too ill to come out. So I think that that's going to be something that will come up in your own groups. Well, I just went and I got medicine because I was feeling bad. I didn't get the shots, but I got the medicine because I felt bad, and maybe I home tested. We do know that the home tests that are being done really stifle the true number of actual COVID cases. And so the numbers that we give out aren't really as high as they really are, but that was just a third section. And that's where I am with what was said so far, but I really agree the messaging is the same and it has to be simple. It can't be a whole bunch of things that are there. You have to have under 50 words as far as what the people say who try to say how to get out a message to various ethnicities, etc. Once you've hit 50, it's gone. No more is heard. Thank you.
We'll take one more comment. Thank you, Dr. Bruce, Dr. Abalata. And then for those, there will be more opportunity to give more feedback. The purpose of the meeting tonight is to really talk about how we are adjusting our tactics in the moment. This is not future 5-year down the road planning. These are tactics that we are shifting as we speak. And so we want to hear from you to know, what are we moving in the right direction? Are there things that we need to double back on, bring back some things that we let go of, add some new things? And that's what we're going to be talking about in the breakout groups. So this last comment will go to, or question will go to you, Dr. Abalata. Take it away.
Thank you. Yeah, I think the big concern that I'm just really hearing is sort of, we don't have the best grasp of, how serious things are at the moment. The surge that we're in now is, it's sort of, we haven't come down to a level that feels comfortable. We're plateauing around, we're bouncing around with these hospitalizations and things that are at a little higher level than is comfortable. And we've got this new, much more contagious variant coming before we could kind of get over the hump from what probably was the variant before. And yet that picture is not, I think, made clear to the general public. I think for a variety of reasons, not least of which is this idea that we're trying to so-called get back to normal. Masks are no longer required. You're hearing people confused about endemic, pandemic, these things. And so I mean, in some ways I'm repeating what I think others have said, which is that we need not only just a unified messaging, but a very clear message, I think, to folks that we have high transmission going on. We have an even more contagious variant. People are still landing in the hospital. This still can be dangerous for certain people. Those certain people need to get early access to medications. And when I say unified messaging, I have to say that I'm including doctors and primary care providers in that, because I think that up until now, primary care doctors, a lot of them have not really been part of the pandemic response, but then are now sort of expected to just get ready to test and vaccinate and prescribe Paxlovid. And I'm not convinced, I'm not talking about our larger systems, our FQHCs, our hospitals, who obviously are larger clinics who've been part of the response, but those that we're now going to be relying on, I think, more and more as these testing sites turn to charging people, asking for ID or things of that nature, we're going to have to start really looking to our primary care doctors. So I guess when I think about the unified messaging, I mean, to me, I've been so grateful to be here in the Bay Area with the leadership of our public health officer and the Bay Area counties, who got together first and really were the first ones that got out ahead of everybody, right? And said, we need to shelter in place. And who knows how many thousands of lives that saved. We've been more conservative on masking all along, including OUSD under their leadership. How many thousands of lives has that saved? And I think part of the power of it was the Bay Area counties all getting together and saying the same thing. This is what we need to do to save lives right now. And where we are now, I'm not saying that they're saying different things. I'm just saying that I don't know that the public is getting that clarity of a message of saying, this is a situation we're in, these are the things that we need to do. And then having that just repeated, that we're all just repeating the same thing. Because what I'm seeing out in practice is people are back on airplanes, they're going to conferences, they're getting COVID. We are accepting suddenly a level of spread, a level of transmission, a number of super spreader events and outbreaks that we are just allowing to sort of happen. And when I say we, I just mean the big we. But where's the guidance for people to say, to make some decisions about how to safely have a conference? Not just, we're just gonna all throw off our masks, get on planes and go to conferences, have super spreader events and keep getting infected and reinfected, and we'll deal with long COVID later. That just strikes me as, crisis after crisis that we're gonna be dealing with for quite some time. So I think, the unified messaging and making sure it's reaching everyone who it needs to reach, I think is really going to be critical at this point, including how do we know how we're doing? How can we be really clear with everyone how we're doing when we're not going to mandate things, probably very much anymore? Or when are we going to mandate things again? Is there a threshold at which we say, you know what, we got to bring masks back? And, I think that would make a lot of people a lot more comfortable in a lot of spaces. But then it's the double-edged sword of what others have said, is that, well, then when you have to inevitably lift it, then are people going to just assume, okay, I don't need to mask anymore? And so really should the message be, you know what, regardless of what anyone says about a mandate, you need to be wearing the masks. So I think whatever that is, we should get on the same page about it. And it should be on billboards, it should be on sound trucks, it should be on flyers, it should be in every language, it should be on TV, and it needs to be everywhere, because it does feel a little bit like we are losing the ability to communicate with the public about this pandemic in a way that is clear and truthful and current. And it is leaving people to assume that it's over, and it is going to therefore prolong this situation more than necessary.
Thank you, Dr. Abalada, for that. And this is a perfect segue to Dr. Moss. And then we will still have, and we are going to have a compressed update, but a time for Dr. Moss to give his update. And then we're going to do the breakout room so we can talk more about our tactics and strategies and what we need to do to meet the moment that we're in right now. Dr. Moss.
Thanks, Director Watkins-Tart, and good to follow Noha's comments, which I agree with, and then I was about to type in the chat, but now I get to say it. Congratulations on your award, well deserved. So I just have a few slides. I think Donata Nilsson is on as well, our COVID Division Director, will come on after me. A little bit different order for me, so we'll see how this goes. Just a brief summary. I think you probably got this from the conversation already, but there's a lot of COVID around. We have a lot of COVID around, perhaps as much as we've had at any point in the pandemic. No doubt many, if not all of you, are experiencing this in your work and personal life. We did have a period of calm. The best over the last 3 months, the only time the indicators were sort of moving either stable or moving in the right direction was in the sort of beginning and middle of June. But then we saw another pretty striking increase in our available metrics in late June, maybe due to the emergence of the BA.5 variant. That is likely, although I'm still waiting for some of our own local data, but that does seem to be the case. We haven't yet seen as many people in the hospital as we have seen in prior waves, but this has been a slow grinding wave. It's lasted much longer than what happened with Omicron in the winter, and it could continue to last. I don't have evidence to suggest that things have peaked yet, and so I think we do have to think about even if there aren't as many people in the hospital on a given day, if this is grinding on for a few months, that's still a lot of people really substantially affected, not to mention the disruptions that we're experiencing otherwise. And, I think in addition to the variants, it's important to note this really is driven by people increasingly returning to sort of pre-pandemic activities, sort of 2019 lifestyle. And I think Dr. Noha said something similar, but when you go out and mix with other people in crowded spaces and you do that again and again, and you have very transmissible COVID around, you will end up getting COVID. And we're seeing that happen across communities. So of course, we lifted the mask requirement on June 24th during this brief window of stability. It was, I think, we have to acknowledge that we immediately saw increases in our metrics. Again, this is a pattern that has been seen elsewhere and likely does reflect BA.5, but regardless, it was not ideal. But indoor masking remains strongly recommended, and we are big believers in masking. I think the requirement, especially without others implementing something similar, and just with the sort of press towards normalcy in so many places, it is a challenging time for requirements. We also did align with the state on quarantine policy. I think this is less impactful, in terms of putting people at risk from a public health standpoint. I think, masks are very important. Quarantine, probably with the latest variants, that's where you stay home after an exposure. Many people are not aware of their exposure. They're often sick before they know they were exposed. So quarantine likely wasn't reaching enough people fast enough to really have an impact on these variants. And we're now aligned with the California Department of Public Health and Cal OSHA. Quarantine is not required except in some high-risk settings, but in alignment with California DPH and reflecting the fact that COVID is really an airborne transmissible infection. That is the way people get infected. That anyone in a shared indoor airspace with an infectious person is considered exposed to COVID-19. So you don't have to quarantine necessarily, but that is an exposure if you're in the same room with somebody with COVID. Masking is recommended after that exposure for 10 days, and also testing 3 to 5 days after that exposure. And we still require isolation of people who have COVID infection here in Alameda County. So once you get sick, you test positive, you have the symptoms, you should stay home. Next slide, please. So I did also want to mention the state has updated school guidance. We have aligned with the state on K through 12 school COVID guidance for, I think, 1.5 years now. This is, the goal is to minimize disruptions. So the main points of the current guidance, which is much streamlined compared to the past: improve indoor air quality. Schools should follow the mask guidance for the general public. Right now, it's a strong recommendation in indoor settings statewide. The antigen testing should be available for students who are sick. It doesn't necessarily have to be provided by the school, but it's important that students have access to testing. Hand hygiene, of course, staying home when sick, and then the guidance mentions that families should be notified of exposures in classrooms, but children can remain in classrooms after an exposure if they're not sick. And that has actually been the guidance going back to, I think, February. So that's not new. And the goal really is to avoid disruptions, keep kids in classrooms as much as possible. And then also to minimize class closures. This is really something that should be used as a last resort. Again, trying to avoid further disruptions to education. Next slide, please. As I said, data slides, change the order a bit here. This is our hospitalizations in Alameda County. Steady increase through May, peaked on June 12th, about 10 days of improvement. And then in late June, again, things worsened. For about 3 weeks, we were sort of fluctuating between 130 and 150 people in the hospital, got down to the 120s a couple days ago. But I just saw the latest data. Think of 159. So, I don't know how high this will go, but I think it speaks to both just that there's a lot of COVID around, but also that we're continuing to get people with severe disease. Intensive care unit, we're seeing, relatively speaking, fewer people in the ICU than in prior waves. But again, this is sort of grinding on over time, and I think we have to factor that into how we think about the severe disease impacts. Next slide. This is our wastewater. Again, I think a similar message, sort of a period of perhaps some stability in mid-June, but then really substantial additional peak happening maybe right now. We're not sure if we peak yet. They've updated this data. It doesn't look quite as dramatic when you have a few more data points, but nevertheless, a lot of COVID around still. No signs that we're through the peak yet. Next slide, please. We have prepared some videos. We are still big believers in masks. I think people know that in this group. It's a great, simple, non-disruptive way to protect yourself. I mask all the time, even though I try to sort of, I'm out and about in a lot of other ways, but I have my mask with me. I'm wearing my mask, and it's a great way to keep yourself from getting COVID when there's so much COVID around. Next slide, please. And I hope I wasn't supposed to play that video, but okay.
No.
Back to you, Shimi.
All right. Thank you. So we're now going to go into the breakout groups. This is where we can have more detailed conversation about what's happening now, what needs to be happening, what needs to be changed, and how we're responding right this moment. And so the team is going to divide everyone into groups, and essentially you will stay in the group that you're assigned to, and the facilitators will move around so that each of you has the opportunity to comment on different parts of our COVID response. Lauren, Julie, do I have the instructions correct? And are you going to take it away?
Yes, I can take it from here. Thanks so much, Kimmy.
All right.
All right. And thank you everyone for the comments that you shared earlier. We do want to capture what all of you have to say. And so we created time in the breakout groups in the next, well, for the rest of the meeting, really, that we're going to go into. I want to just set the stage, give a little bit of context. As you recall, back in May, we started this process to do a strategic refresh update. We went over the high level activities and what some of the goals are. Our June meeting, we really focused on the masking orders. So we're picking up again on the refresh process this month. And we plan to conclude this and have a new strategic plan that incorporates the input you've given us by the end of August. So we'll be coming back to you with a draft and see if there's things that are missing and other additions, and then we'll be finalizing our strategic plan. So we really appreciate your input. Next slide. So the one thing I just want to remind you, this is our one-page summary of the strategic plan. And I just want to lift up that the 4 goals have not changed. And so each of the breakout groups is going to be relating to one or the other of these goals. The first goal focusing on prevention, the next one on testing and supporting people who have COVID. One of our key goals is really to reduce racial and ethnic health disparities. And finally, looking at how do we build our public health infrastructure. Our breakout groups, we want to focus on, if you go to the next slide, please. We want to focus on those areas where we can actually do something. That's fine. And we want to focus on those areas that we can change based on your feedback. So this is how we've decided to break out into small groups. Group 1 will be focused on prevention and vaccines. The second one is on testing. The third one is on community support. If we had had more time, we would have had a fourth one, which looks at community engagement. And that's something we can certainly pick up on in our August meeting. So we've deferred that just because our time has run a little bit short today. And that basically our commitment to equity is built into all of these different groups. The way it works is we're going to divide you randomly. Those people who are from the CAG, not necessarily from the health department, are into breakout groups, 1 of 3. And then we're going to have facilitators that focus on vaccine for about 12 minutes, I think. We're going to try to squeeze out as much time as we can, maybe 13 minutes. And then what's going to happen, we're going to teleport your facilitators with the same questions about vaccine to the next group. So everybody who's here will have a chance to give input to all 3 of these different topic areas. The health department staff who are here, if you're not a facilitator or a scribe, that you'll be going into a green room, a separate from the breakout groups. And this is really, we want to focus on our community, the input from all of you that represent different parts of our community. So with that, what we're going to do is,
sorry,
that's okay.
I moved my, never mind.
Quite all right. So what we're going to do is break you into your 3 different breakout groups. And after about 13 minutes, Lauren's going to automatically shift. You'll get about a 1 or 2 minute warning. Then she'll shift the facilitator to the next group, which is sort of the same as changing groups. And the way we have it set up, we're using a Jamboard for the first time here. So this is, I hope it'll be fun. And it's a way that it's the same as a sticky wall where you yourself can place comments on the wall, or we have a scribe in each room who can put comments on the wall for you. So with that, I think we're all going to magically go into our 3 groups, and we look forward to getting your feedback. I think, let me say one more word. Let's see, have we switched yet, Lauren?
Nope, I have not switched yet. The only thing I was going to share was for folks who would like to participate in Spanish or sign language. That's going to happen just in the main room. And so if you get sent somewhere else, or are participating in that way, I think you should come back to the main room.
Okay.
Yes, you can come back to the main room and I can reassign you. So one of the 3 rooms will be people just staying here. So if you don't get teleported, don't be scared. This is where your room lives.
Okay. 2 thoughts I want to leave you with as you move into your breakout groups. One is that we are the health department and all of you are part of a larger public health system. So when we think about what's the most important things we can do, I really hope that folks think about not just what the health department can do, what can our community partners do? Where is it that we need the resources that we have in our community, all the organizations that you work for, what are things that you all can do as well to support each of these areas? So please keep that in mind. The other thing to keep in mind is that we are at a time of reduced resources. FEMA funding is starting to dwindle down and it will soon go away. We have grants that were here for the emergency that will be that are narrowing down, and some of those will be going away. So as our resources start to tighten, how is it that we can most effectively direct the resources that we have? Again, we being the collective, all of you and us together, how can we work to be most strategic to have the most important impact on our community's health? And with that, let's move into breakout groups. Thank you so much.
Right here we go.
As we're breaking out, I'm just wondering, did the public health department apply for the $3 billion? Does anybody know the CDC $3 billion?
I do not know, this is Lauren, but I sent all the public health people to a breakout.
Because actually, I think those applications are coming.
With the exception of
myself. There's still an opportunity to get money.
Okay, so I believe our facilitators here are Drew and Joanne. Do you want to get started?
Thanks so much. Hi, my name is Drew Jasper. I'm joined here with Joanne Luby. We're both nurse supervisors for the COVID division. We've both been a part of the COVID response since the spring of 2020. It's a privilege to be here with you. Do we want to just, we don't have a whole lot of time before we jump in. Do we want to do quick names and where you represent in our community?
It's up to you, but most folks know each other.
They know each other. Okay.
Yeah.
And I'm just going to share screen and I'm going to jump right in. All right. So Joanne and I represent the COVID investigations unit, where we focus on disease containment and the overarching goals of making sure that we can support testing, isolation, and provide supportive care when people have COVID-19, along with education and behavior, protective behaviors that they can take for themselves and for their loved ones, and also address the racial and ethnic health disparities that we know have impacted different communities, both in Alameda County and across the nation. What we've done previously, we had vaccine call lines, inquiry lines, community support teams where we provided financial assistance, $8 million of ARCH stipends sent out directly to residents, ISO care kits, food delivery, other needs resources provided. We partnered with really wonderful community-based organizations to help provide case investigation and contact tracing and education to the communities that they work with and know. And we used prioritization when the surges were so great. We used a prioritization strategy to make sure that we were reaching the communities with the highest transmission rates and also the communities with the lowest vaccination rates. And we know that that overlaps with inequities that affect communities that are mostly Black or Latinx or immigrant or Indigenous. As we shift into new operations, we're combining all of those community resource teams into one group with one phone number, one email, so that there's one place that somebody can reach out to the public health department for assistance. We're doing some proactive outreach to try to make sure that communities that need education and navigation for medications can get that help. We're sending virtual agent surveys to everyone that's a new positive and reported, so that we can still provide feedback to them through technological ways, as well as collect information from them if they're willing to give it. We partnered with community coalitions that are just building up and going live this year. And we're going to need to provide referrals more for financial assistance to food banks, to shelters, to our health insurance technicians. And then we are really focusing our case investigation work towards unusual outbreaks or high priority outbreaks where there are populations involved that are most at risk or most vulnerable. So what we're going to be doing today, and you'll be doing this in each rotation, is my coworker Joanne, she's going to post a link in the chat, this Jamboard. If you've never used a Jamboard, it's pretty simple. We're going to invite you to go to actually go to the Jamboard and provide answers onto it if you're comfortable doing so. And in order to do that, once you're here, all you have to do is click this little sticky note button. And if you want to answer the question of how aware is your community of COVID treatment options like Paxlovid, like monoclonal antibodies, click this sticky note. You can change the color if you'd like, and you're going to say, you might say something like Hayward, not very aware. And you can click save. Then you can add another sticky note if you want, or you can just go to the board, take your sticky note and put it underneath. You can resize it. And if you want to edit it, you can click the three dots and edit or delete. So invite you to do that. And I'm gonna also hand it over to, the other part is, this is the first of three. So we've got 2 questions on this board. And then you can click up here to the second question, and then click again to the next slide for our third combo of questions.
All right.
Yeah.
Good evening, and thank you for bearing with us. This is a new sort of platform we're trying out, so I hope you enjoy or have fun with it. If anyone is not comfortable, going onto the chat, actually, if anyone wants to try it and let me know if it's working, that'd be great. But I can also use the sticky note if you want to verbalize something, and I can put it in a sticky note and put it onto this Jamboard here. So again, sort of the questions that we'd love to get some answers to are, how aware is your community of COVID treatment options? And what are the barriers to access to those treatment options?
You're also more than willing to come off mute and provide your answers to us, and we can put it on the board.
Hello, this is Shirley from Street Level Help Project. And when it comes to question number 1, how aware is your community of COVID treatment options? I feel like when it comes to testings, I don't think like treatment, it's a testing, but it could be part of it. But I feel like people are more aware that there is an existence of vaccines, right? But I feel like they don't fully know that there's a treatment like the Paxlovid treatment, right? When it comes to that type of treatment, they're not aware. And I think if I was to go out to the community and start a conversation and ask them about it, I'm pretty sure the majority of them don't know the existence and where to access it. And also, if they were to access it, I feel like there wouldn't be a lot of places that have an easy access to that treatment.
Thank you for that. See, I'm looking at some of the other sticky notes here as well. Marginally aware, not generally. Aware of limitations related to the timing or initiating oral treatments. And then on treatment options, I think it's been very little info. Most folks don't have good resources to learn about what is available. Yeah. So these are, kind of encompass both questions, it sounds like. Sounds like maybe not a lot of awareness, and also not, just the information isn't available to them. Is that sounds like what I'm reading here.
Yeah.
Yeah.
Let me add a little bit to it. This is Greg. Hi, everybody. You know, and I think that part of my comment is in one of the sticky notes, and I think it is compared to testing and vax, it's sort of like a very, very distant third. But I think we put so much emphasis, and rightfully, on those two other sets of activities with the set of credible messengers, people like Dr. Rose and Mojo Health Project, others. And so I think that it is really one of the weakest areas of communications that I'm aware of.
Right.
Really important. If you have more to add to this one, you can stay on this one. I'm gonna, to make sure that we cover all 3 slides, I'm gonna click to the next one for now. We can always come back to if you wanna come off mute and ask to go back if there's something you wanna discuss.
All right, so how do communities learn about COVID vaccinations, testing, and treatments? Again, the Jamboards are fun. I do enjoy hearing your voices as well, though. So feel free to come off mute and, you know, have a discussion as well.
I'm having an issue with internet, but I'll just say, as for Street Level Health Project, I think the best way community learns about vaccine testing and treatment is through in-person outreach in the community, like street outreach. Also, phone banking, like calling a list that you already have, and also the best way is like making the material really like straightforward without adding too much word and more visual, because we don't understand, a lot of people don't really read much or they don't have the literacy capacity, so I think visual could give them an idea. So, but I think as for street level, like in-person outreach has been the best way to reach people, but also educate them in the language that the access language that we have, which it's like English, Spanish, and also mom.
Host a weekly, now every other weekly meeting. On the ground mobilization. Trusted sources telling them during typical interactions with them. So just in sort of conversationally. All right. And then Drew, do you want to move us to the next one?
Yeah, looks like we have 2 minutes left.
Can I just say something on that last board? I just typed it in the sticky note just because that way I guess you'll have it. But we have been conducting a survey since February, since late February, after when we knew the mask mandates were going to come off. And we always ask, what is your primary source of COVID information? And I listed the top 4 in that order. And I think the reason I'm trying to emphasize that is because it's instructive about where public health may not be messaging accurately. So television is number 1 by far. Second thing is social media. Third is friends and family. And then the 4th is public health and the CDC. So the public health department, I think, needs to be on TV and on social media where people are, not just like, Twitter is probably not the right space, but Instagram would be, for example.
Thank you, Kim.
Yeah, very informative. Thank you.
So I will probably magically disappear in about a minute.
I've been dropping. This is Lawrence. I'm about to move you guys. You get the
Thanks,
pleasure of knowing.
Thank you.
All right, I'm going to move you now.
Thanks.
Okay, I tried to move. Oh. Come on. Sorry, everybody. Everyone moved except for the people who are supposed to come in here. Let me try to move them somewhere else. Okay. Shoot.
Hello, everybody. My name is Mark. Is this the main? Is this the next room? I believe it is. Nancy, you're here? Okay. My name is Mark Johnson. I work for the Public Health COVID Division. Some of you may have met me before. If not, I work mostly with vaccination clinic coordination. I'm going to share my screen here. Excuse me 1 second. The transition from one room to the next is a little difficult. There we go. All right, can everybody see my screen?
Yes.
All right, thank you. So I want to talk about our prevention strategy as it's related to vaccinations. As many of you know, we moved from a mass vaccination model at the Oakland Coliseum. We were doing 1,200 vaccinations a day at one point there, and transitioned into a larger community-based model. Fremont High School would be a good example of a clinic that we were doing 200 or 300 a day there. At that point, you could pop up a clinic anywhere that had a big enough entrance and a big enough auditorium. And, so many people were making appointments that it was really just about location and availability. Later in this pandemic, we got to a point where we were doing smaller community-based clinics. These were reoccurring on a weekly basis. Working close with all of you, we got great feedback on what hours those clinics should operate. The transition from the mass vax model to the community-based vaccination clinic model has really been a progression in the sense that, working together with community partners, we're able to dissolve some of the barriers, whether they be digital barriers and registration, language barriers at the actual clinic, and definitely improve our services over time. Those community-based model weekly reoccurring clinics operated for months. We did a lot of the school age children vaccinations at those clinics. And it was probably around April that we started seeing a really reduced amount of people showing up at those clinics. There were three models of service at that point: our community vax unit, our mobile vax unit, and our in-home vax unit. And it got to the point around May where the in-home vaccination service was actually vaccinating more people than we were vaccinating at our reoccurring community pods. So we got to a point where we decided to transition out of those stable clinics. If you looked at it on a map, you'd see that, Allen Temple is a good example in East Oakland, that we had a circle around Allen Temple where the vax rates were much higher than the rest of East Oakland. And then pockets all over East Oakland that still had really low vaccination rates. And so our strategy since then has been to make the mobile vaccination clinics and the in-home vaccination clinics much more accessible to the community. We partnered with the HPCP, the coalitions, to try to work closer with the community partners and figure out, just where is a good place for a vaccination event, whether it be the Juneteenth, the town nights events, or an event hosted by a community partner. So that's where we are now. Nancy, if you want to share your screen, we can transition to the questions. Does anybody have any questions about that before we move on to these specific questions?
Sorry, I'm so used to Teams. I was trying to find the unmute button. Can everyone see my screen?
Not currently, no.
Uh-oh. Okay, let me try that again. Maybe I'm doing the wrong one.
We can see your screen.
Oh, you can see it now? Okay.
I can see it. I don't know why.
Okay, so this is this Jamboard. This is the question, and there's some comments here from the last session. These are in no particular order. So the link is actually in the chat if you wanted to open it up on your own computer. Otherwise, I can just type in notes if you have comments on any of these things, or if we want to add more sticky notes, I can do that also. Does that make sense?
And people can add their own sticky note, right? Can you show how to do that?
Yeah, so you just click on this right here, and I don't know, I can't think of another barrier right off the top of my head. We have a lot here, but if you want to add a note, you just do that and then click save, and then you can change the color if you'd like.
Great. So the question is, what system-wide barriers need to be overcome to make access to vaccines equitable in communities disproportionately impacted by COVID-19?
Hi, can you put the link in the chat again? Because if we just switched rooms, so all we have is the link to the previous Jamboard. Thank you.
I think it's the same link, but yeah, try it and let me know.
No, you did it. Yeah.
Okay.
Nancy, whatever Nancy posted, thank you.
Great.
That's it.
Welcome.
Does anybody have any responses? Dr. Rhodes, you want to open us up?
Yeah, I mean, I'm struggling with this question because I feel like it's packed with stuff, like all of the things that we see here that are kind of traditionally what we think of as structural. I largely agree with. I think what's missing for me is the relationship, because right now where we are is an emotional, it's an emotional thing, whether or not you're getting vaccinated. It's not really about is the science good and can you get there, right? It's whether or not people are actually interested and whether or not it's a priority. So I feel like the way to get at that is about the relationship with the communities that you're talking about that are disproportionately sort of not having access. I think Alameda County has actually done a pretty good job of making sure that that there are either community partners or the public health department meeting people where they are. And I think you gave those examples. So I don't know that. I'm not saying there aren't barriers, there are, but I'm saying if you smash down all these barriers, I don't think that right now that you're going to change people's interest in vaccination. And I think that is a reflection of kind of what we've been through in this pandemic, not just in terms of being tired of it because it's 2 years, but also the whiplash of do we have it under control? I think we do. No, we don't. Now here's the vaccine. Oh, actually, it doesn't prevent COVID. Here's another vaccine that you're going to need because actually that other one wore off. I don't even know if I can really put anything down on here that I feel like if we address it, that's actually going to be the thing that moves the needle. Because I think a good job of making it mobile, we're going to people's houses, being in neighborhood, being partnered with folks who can actually mobilize their people. I just think we're vaccinating the same people over and over again.
Yeah,
thank you.
If I could add a little bit to that. So I want to just almost double down on what Dr. Rhodes has said. I think that one of the barriers right now that I'm noticing is that the sustainability at scale of all of the street level folks that, you know, Kim and Gabriella and Roots and other folks that work with, because the way county resources have been not flowing, it means it's this start and stops. And the idea that, you know, we are going, it's almost like we fell back to our traditional public health network, if you will. And I think that a barrier going forward is to help people understand that when we really say we want to be working in a sustainable way on a range of social determinants of health in the community, that we have to have those street level promotores and navigators. It can't be this sort of ad hoc thing. And so for me, I think it's a structural barrier based on how the county funds, the way resources and RFPs get structured and all of that.
Yes, sir. Thank you for that. Nancy, if we could move on to question number 2. What approaches to COVID vaccination efforts should be continued?
What I just said.
That again. Copy and paste.
Copy and paste. Rinse and repeat.
I mean, we have this mobile vaccination effort, you know, send us in an interest form and we'll pop up a clinic, right? But that's only part of it. You know, the clinic is no longer about location. It's about relationships, as both of you have described. And it's clear when the relationship isn't there, people don't come to get vaccinated. It's also clear, like street level health in the Fruitvale Clinic, when the relationships are there, people are still getting vaccinated. So does anybody have anything to add to this question? What approaches to COVID vaccination efforts should be continued? Well, we got another question. I don't know if you all know, this would be question number 3. We're planning a co-location of flu and COVID vaccination clinics with the school districts. And does anybody have any input as far as, you know, what might increase uptake at clinics? Like we've already talked about, I mean, I'm sure we all agree, holistic health is very important. We can't just, you know, ask everybody to get vaccinated without addressing other healthcare disparities, right? That's clear. But let's put some of this in writing if anybody has any statements about that, because this will guide the future of vaccination clinics.
Somebody mentioned on the first question about looking at other diseases along with COVID. I could add that.
What is it, Dr. Rhodes? We need an inflatable colon at all of our clinics.
Yeah, I was just writing deprioritize COVID.
Yes.
Like it's a side dish. I mean, we used to say this all the time. It's like, oh, it's going to be the side dish, not the main course. Because then there's not the pressure there. It's just like, oh yeah, this is here, but nobody's kind of pressing you. I think we can come across as if our primary agenda is to get you vaccinated.
Right. And why?
Feel oppressive. So yeah, if you've got an inflatable colon, people want to come by because the kids like to punch the polyps. They bring their parents behind them, and then you've got these other things that you're offering. And I would include in the other things that you're offering, not just health stuff either, right? Like something fun that people actually want to engage with because they want to engage with it, not because it makes them healthier. Again, like the eat your vegetables messaging is like, it's not that sexy.
Yes. Anybody else? We're probably going to transition here in a couple of minutes.
All right, well, because I'm in this room and I'm the breakout person, sounds like a good transition. Everyone else is just going to get moved in the middle of mid-sentence. All right, I'm going to try to move people now.
Thank you, everybody.
Thank you, Mark.
Sorry, folks, I had to go retrieve your facilitators. They're coming.
Right. Hello, everyone.
Hello.
Sorry for the delay. Tuweri and I are going to facilitate this next session with you. So I think everyone here probably knows us. We've been on the CAG call many times. So I'm going to share my screen briefly just to share with you our focus for this group. Give me 1 second. Share. Okay, and can everyone see that? You are sharing screen. Am I sharing the right screen? Not sure. Let me see. Let me try one more time. Sorry about that. This one. Can everyone see the slide? I don't know what's happening.
We can see it.
Okay, good. I don't see the green perimeter.
It's going. It's
okay.
on.
So current slide. So our focus for this session is disease containment, focused on testing. So I wanted to just share a few notes. Previously, we've been really focused on PCR tests because that's what's been available to us. And we've been really focused on providing testing to anyone that comes to our testing sites. So basically universal testing. And our focus has really been on community sites where, where we have priority neighborhoods that have been highly impacted by COVID. Some of them may have low vaccination rates, but are also high positivity. So we want to make sure that they have available testing. But as we move forward, as you heard Julie say at the beginning, our resources, federal resources, are going to start dwindling slowly. So in the next year, we really want to focus our attention to uninsured and underinsured individuals and really direct individuals who have insurance to their providers. So we've already been working closely with many of our providers to work on messaging to their clients. We are moving towards rapid testing, really moving more away from PCR, although we will continue to have PCR available at some sites. But we do really want to maintain an equity approach. So we really want to make sure that where there's low vaccination rates and high positivity, we continue to make sure there's language access and testing access in those areas of our communities. And then as you've heard us start talking about treatment options, all of our OptumServe sites offer treatment, test to treat, but we really want to make that and expand that treatment options at all of our testing sites as we move into this next year. So with that, I'm going to turn it over to Tuweri to get us started with the Jamboard.
Great. Thank you so much, Donata. Hold on 1 second. Can you stop that, please?
Thank you. So what you see here, and it seems like people are in the Jamboard, which is really exciting. Thank you for that. So if you haven't used a Jamboard before, you can, the link is in the chat. You can go ahead and go in, and to answer the questions, you just click on the sticky note, type in your answer, and then it will populate to the Jamboard. You can see here on this page that it's pretty filled up. These are some of the answers from the previous two groups. And I'm just going to move over to the second page just so we don't jam it up too much. It's okay if things are repeated. It's totally fine. We'll sort it later. So Donata, do you want to answer or ask the question?
Sure. So the first question is, what are you hearing from your communities about access to test sites? And what are the barriers to getting tested? So we'll spend about maybe 2 to 3 minutes on this, and then we'll move to the next question.
Just out of curiosity, is this question being asked as a way to address, for example, the dramatic drop in testing, say over the last 2 months, from 11,000 tests per week to 5,000 or wherever we are?
Yeah, I mean,
what is the goal here? Because if people aren't interested in testing, again, what are people's priorities right now? And I'm not convinced that testing is one of them.
Yeah, I think the goal here really was to see if there is an issue with access. We want to continue providing testing to our communities, but if you've heard anything about access, and you're saying that basically people are not coming to get tested, for our community testing sites, we have had pretty high testing still. Maybe for the overall in the county, maybe that has reduced a little bit.
I think Nick just presented it to us at Emoja. It's cut in half in the last months.
Yeah. And then I think Dr. Rhodes, also what you just said is important, information it's just not people's priorities. If that's what we're hearing, out in our communities, whether it's at test sites or otherwise, that's super helpful information.
Any other thoughts here? Did you add that one to it?
Is that indeed what you're hearing, Dr. Rhodes? Is that it's not a priority for people to go out and get tested?
They don't care. They're people are done. They're sick of COVID. And when you're talking about COVID, they're kind of yeah, whatever. Once when Omicron hit, that was a time when people were trying to desperately find a test and driving all over town looking for a place to get tested. It seems like the general attitude right now is, I have a rapid test at home, or I don't have COVID. That's another one.
Yeah.
I have allergies right now, so I'm not going to test. There's no reason to test.
Are you hearing anything about the use of at-home tests?
Yeah, so we have a survey that we're conducting on attitudes, been longitudinal since February. And we are asking people, do you have access to rapid tests? And I think it's about 75 to 80% of people feel like they have easy access.
Any other thoughts on this one? Otherwise, we can move on to the next question.
Shirley has her hand raised. Go ahead,
Shirley.
Sorry.
Yeah, I think when it comes to me, because I do a lot of outreach in the community, and I do provide home rapid tests for people, but then there comes that question, how do I use it, right? And it's easy for me to open a rapid test, and of course I'm not doing it myself, but kind of like show them through the air how to use them, right? Just kind of just do a play role how to use it, but don't really test myself right away, because you never know, and just show them how to do it. But when it comes to my indigenous community, I could say the indigenous community I come from, some of them do have a really lack of literacy and don't know how to read or write, and so that even becomes a huge barrier for many people to use them. So as much as you just provide them a testing kit, here you go, try this, do it at home, but then it comes that I don't know how to read, I do not understand what's saying or how to use it. So you have to actually really visually do it. So what we have done with our team, we have put it barcodes in our flyers where we tell them, can you please like try to use your phone? And even technology becomes a barrier because a lot of them don't know how to use a phone or how to scan a barcode. And so it does sound so easy for us to say like, oh, let's provide home rapid test. That's the new access. That's the easier way to take the test. But in reality, like, let's be honest, like that is one of the, like, that's another huge barrier that I feel like we don't really take in consideration, that a lot of people don't know how to read, how to write, or don't know understanding or so. And sometimes I've heard a lot of organizations, including us, right, we provide rapid tests, but do we take the time to ask them, like, are you going to understand how to use this? So that's why we hear a lot of people say, oh, I'm sick of this, I'm sick of that, because it's hard for them to use it.
Yeah. Thank you,
So
Shirley.
that's
Yeah.
what I've seen and heard, and I think it's more than that. It's more than not wanting it to do. It's just like the difficulty behind it.
Thank you, Shirley, for that. That's very helpful. All right, let's go to the next question. I think we have about maybe 2 or 3 minutes left. What locations, 2 minutes, should county-led testing services consider to increase COVID-19 testing? And then if you want to comment on the other one, how can CBOs partners support community testing access? So either one that anyone would like to comment on. And Shirley, I assume that's still your hand from before?
Yes. I'll put it back.
Okay.
I don't know about the rest of, well, this is just for PCR, and it may be irrelevant, so I'm not going to say it. It's old. But what I don't understand is, because we have so much rapid testing and it doesn't require a lot of personnel, like why we don't have, and this was my fantasy in March of 2020 or April of 2020, it's like, why don't we have like small tents with some kind of personnel in the tent on every corner, so that you have access in every neighborhood. And I'm not saying public health department should do that. I'm just saying, why don't we have that? I mean, it's not difficult to administer or to help people walk through it. It would address the problem of folks who maybe can't read or really need some help getting through the test in real time, and then it's available right on the street. I'm not sure why that's not yet a model.
That's a great comment.
Where you staff it with a whole bunch of people who sit around and do nothing because you're going to test one person or two people.
Yeah. Great. Great comment. Thank you. Anyone else? Anything that you'd like to share in the last minute? Oh,
I think everybody's coming back.
Yep, so it looks like we're coming back.
All right.
Thank you, Tori.
Thank you. Thanks, everybody.
Great. Let's see. It looks like everybody's back in the main room. Welcome back. And let me just check in with the group. Thank you so much for participating. It's the first time we've done something like this with the Jamboard. I'd love to hear from folks how it went from our community partners. Is this a good way to get some feedback? I'd love to hear just any thoughts on if this was productive.
This was very productive. Yeah, I want to thank all of the facilitators. The implementation of this process is what is exactly needed. And, I think the last statement in our last group is I would love to see an avenue by which the grassroots organizations, our CBOs, could be collective in their messaging, but then also how that same grassroots collectiveness would be able to message from the community back to the public health department, right? That's what's being missing, right? We're not hearing what the people are saying, and it needs to get to the people that matter. And the CBOs are that middle link that could message both ways.
Great. Gary, that's great. Other thought, feedback on this? Yes, let's see, who's Pastor Arlene?
Yeah, gotta find myself in a moment. Yeah, so I appreciate this very much. I think this is really constructive. I feel like I could be a better contributor if I had the questions a day before or just even the morning of, because okay, I've been here 20 years and I like to think I know the place, but COVID is an evolving thing and stuff that we haven't dealt with before is coming up and everything. And so I would really appreciate the ability to kick these questions out to our frontline people. I feel like we would be stronger and get their input so that I could bring it on behalf of our team.
Great, thank you. So we welcome any other input. I'm going to have to ask by email. I want to turn it back to our co-chair, our director, Kimmy Watkins-Tart, to close out. It is 7 o'clock and I do want to be respectful of our time.
Just want to say thank you very much for all your participation. We will take all of your inputs to integrate it into our strategic plan. Remember what I said earlier is that this is not a plan that will be implemented like 3 years from now, that these are tactics that we plan on implementing like next week. So because COVID is moving fast daily, constantly. And so we have to shift quickly as well. So we will bring back to you though, what we integrated. And if there are other comments or questions or feedback you want to give us, please don't hesitate to send us an email. Lauren, is it okay that they email you?
Yes, yes.
Yes.
Okay.
Yes. Sorry.
Yes, she was hesitating. Please email Lauren Baranco if you have other comments that you did not get an opportunity to give. And again, we will bring this back to the CAG. But please know, for those of you who are out there, and I think all of you are out there with us doing this work, many of these tactics you will see implemented in very short order because we got to move fast. We don't have a lot of time. Got to keep it moving. So thank you everyone for all your work and have a nice evening.
Great. Thanks everybody.
Yeah,
Thanks so much.
Good night, everybody.